when you want me to start.
Very minor introduction.
Oh, sure.
Okay. So thank you for coming, and this is part of the Melbourne School of Population and Global Health Mental Health Seminar Series. And Sarah Meyer is visiting us from Johns Hopkins, but she's been based on the Thai-Burma border, is that right? And she's going to talk a bit about her experiences there, and we're really happy to have you here. So thanks for visiting, and looking forward to your presentation.
Thanks. So thank you so much for having me to speak today. So as the seminar was advertised as, I'm going to be talking today about research and practice in the field of mental health and psychosocial support in humanitarian settings. And I'll just present a little outline here, and basically what I'm trying to do here is just really offer some reflections and themes that are emerging and that I've identified in the field through some of my work over the past 3 years, and really illustrate that with particular examples from research and fieldwork that I've done, rather than really presenting in-depth data from one particular study. So my overarching question is, what are some of the important research questions in this field, in the field of mental health and psychosocial support, or the acronym MHPSS, and how does this research translate to programs or policy in the field? I'm going to illustrate that with some examples from my own research and from projects and programs that I've come across in the field. The examples from my own work include, I led a rapid ethnographic qualitative study of children's psychosocial problems in a camp in Thailand, and that was with the International Rescue Committee, and it was a Gates Foundation project that we led there. The second piece of work that I'll be drawing on here is just recently published a global review of the UN Refugee Agency's MHPSS programs and policies, and that involved over 50 interviews with different key informants from UNHCR and from other international NGOs and field workers. And I'll draw on some of those quotes and some of the findings from field staff and the online survey that I did for that as well to illustrate some of my arguments here. And the third piece of work that I'll present a little bit about today as well is my dissertation research, which is a mixed method study of migration and mental health on the Thai-Burma border. So I'll finish up with some examples from that. And so the key questions that I wanted to address in today's presentation are, the first one is, how can research generate evidence in the field of MHPSS in humanitarian settings? And secondly, how can this research inform interventions in the field? So really looking at what are the connections between research and data that's being generated, and what is the impact on actual field work and programs in the field. And then thirdly, just to offer some thoughts and reflections on how the fields of MHPSS and the broader field of the movement for global mental health relate to each other. So I wanted to start here with some definitions which might be very evident or familiar to everyone in the audience, but just to get everyone on the same page here. So MHPSS is defined in the Interagency Standing Committee guidelines as any type of local or outside support that aims to protect or promote psychosocial well-being and or prevent or treat mental disorder. So this is a very broad definition. And first thing to note here is that this definition in some ways was a very political and pragmatic approach, a way to really address a field that had been quite divided between practitioners and researchers and field workers who approached these issues from a more medical, psychiatric, mental health perspective, and another part of the field that was really looking at this in a more psychosocial way, and were often protection workers and social workers. And there was quite a lot of animosity or some divide in that field. So coming up with this acronym and coming up with this definition was really a way of building consensus and bringing people around the same table to be talking about the same thing. So it's really this composite term to bring together the different approaches. But I would also argue that it's also a very logical and actually rigorous approach in that it's grounded in a public health approach to mental health. So what you have here is a recognition that whereas we might address mental health at a population-based level on psychosocial issues, you might have community-based supports or social supports, coping mechanisms that you'd be trying to address in a broader sense, and at the same time that those activities are connected to clinical mental health and specialised services for people with further needs. So in some ways, it's both this sort of composite approach in order to build consensus and get people around the same table, but it's also a way to really approach these issues from a public mental health perspective. And I would also note this is a very broad definition, and that's because this is really an issue that's addressing many different segments of the population and many different issues. So MHPSS might be addressing people who had pre-existing psychiatric needs. In any population, you'll have people with schizophrenia or bipolar disorder. They're displaced or affected by a disaster or a conflict, and their needs are supported by MHPSS. There can be people whose problems are directly related to the humanitarian emergency. So they've been exposed to violence or lost family members, and those are psychological issues that come out. And then also that there are people who have psychological issues or psychosocial issues that emerge from conditions of displacement. So you have long-term refugee camps and the issues that come about from delivery of humanitarian aid or the uncertainty of living there. So that's just an overview of some of the very different types of needs and populations that MHPSS is really addressing. So just to touch on here, the two different definitions that this is made up of. Mental health is defined by the WHO as a state of well-being in which an individual realises his or her own abilities, can cope with normal stresses of life, and can work productively and be a part of their community. So this is really a positive sense of mental health that is not just the absence of mental disorders. At the same time, when that's used in this field, it still often refers to a more clinical psychiatric approach to MHPSS issues. And thirdly, there's the word psychosocial, which has been quite contentious in this field. In the research I did for UNHCR, a lot of people are still quite resistant to the word and find it vague, or that it doesn't really address the problems or the issues that they're coming across, and are seeking more definition and clarity around it. Usually it's used in order to really emphasise the interconnections between psychological and social impacts of humanitarian emergencies. So people may have psychological changes, there may be effects on their behaviour or thoughts or relationships, and also social effects, so change in economic status or social support, and the interconnections between these issues. And I would argue that although there is still these questions about the clarity and the definition of the term, that the inclusion in this composite definition has really brought it to the fore, and there are more people using the word and feeling comfortable with it, and also able to create a more clear, and while it's still an inclusive definition, are able to have more clarity around what really constitutes a psychosocial program. So I wanted to then just talk very quickly about the evolution of this field of MHPSS. So now in the early days of a humanitarian emergency, in the first few days of after the 2010 earthquake in Haiti, when there was displacement in Libya in 2011, and certainly in the ongoing humanitarian crisis in Syria, there's been discussion of mental health and psychosocial needs really from the outset, and recognition that there are significant needs and the need for humanitarian funding and support for these issues. But that really has not always been the case, and at least until the late 1980s, the humanitarian sector really saw its responsibility as meeting basic material needs and not really going beyond that. And if mental health and psychosocial issues were ever discussed, it was really around resettled refugees to industrialised countries and really looking at adapting clinical services to cross-cultural populations. So some of the influences that really brought the field to where it is firstly start from the development of an evidence base. And this was really around research that started to be done, epidemiological studies, prevalence surveys of primarily starting in refugee camps in Thailand. So Richard Molliker developing the Harvard Trauma Questionnaire, using validated methods, using population-based surveys, and starting to really identify and document some of the extent of the impact of conflict and violence and displacement on mental health. The main outcome measures people were looking at were really post-traumatic stress disorder, anxiety and depression. But this was really quite a key influence, and there is still a proliferation of surveys, and they're in some ways also shifting from a focus really on the exposure to violence and conflict and torture to a recognition of the need to also assess people's daily living conditions and stresses while in situations of displacement. So the other thing that really influenced the field is particular humanitarian crises where these issues were brought to the fore. In Bosnia, there was really a lot of strong support and donor funding for psychosocial activities, and particularly the Indian Ocean tsunami. It's not really clear why it was, but possibly it was televised to people's homes. People really saw immediately the destruction and the loss of livelihoods and the loss of social support and community that happened. Mike Wessels, who's a psychosocial expert in this field, said that really more than any event, this really brought home to people the enormity of needs that happen right after a crisis. And it also affected and shifted the debate in some ways in the field, where there was an argument prior to this that mental health and psychosocial needs might be important, but they could be addressed once people's basic needs had been met. And that's still a view that is out there, but really it's increasingly acknowledged that those needs have to be addressed simultaneously and from the outset of an emergency, and that not doing that can also really address the way that people are able to meet their own basic needs and have community resilience and improve community functioning. So the next thing that really started to emerge is some conceptual development. So there was the Psychosocial Working Group, which was a partnership between a number of academics and international organisations that started to develop concepts that have directly led to and been included in these guidelines, including sort of focusing on community resilience, focusing on concepts such as do no harm, and really building on existing resources. And so those concepts, you can see really a very direct link between that conceptual development and the framing that's in the field at the moment. And then finally, and really directly leading to the emergence of the guidelines, is improved interagency coordination. So you had in 2005 the establishment of an interagency standing committee task force for MHPSS. So that really brought to the level of the United Nations this sense of MHPSS being an important issue on par with other issues that there were already task force for, such as gender or HIV/AIDS or water and sanitation. So bringing that issue up to that level really says this is a sector within the humanitarian community, and it's on that level, and we need to have recognition of that. So then what happened then from this improved coordination and from this task force is that the Interagency Standing Committee guidelines were issued in 2007. And so in a lot of ways they really represent a culmination of all of these themes and include in them these principles and some guidelines for how to really respond to MHPSS needs in the field. They also include in them this intervention pyramid, which has been quite influential in the field in terms of language and thinking around MHPSS. So it really grounds level 1 types of activities, so they're broad population-based types of activities, through to level 4 types of activities, and also within this very familiar public health framework where the higher up you go, the smaller segment of a population will need these services and the more specialised these services will be. But this really introduced language into the field that has also actually concretely influenced communication and coordination. So in the research I did for UNHCR, a lot of people say now in the field, we go to a refugee camp in Jordan and UNICEF is there and UNFPA is there and UNHCR is there, and everyone is saying, okay, I'm doing a level 3 activity, we need to link to your level 2 activity. So there's a sense that there shouldn't be overlap, there shouldn't be everyone operating at one level. Whether that always influences the field or whether that always influences practice is another story that's often dependent on funding and levels of expertise and skills. But there's a sense that that's best practice and that's what we're aiming towards. It also was described to me, the Interagency Standing Committee guidelines were also really described to me as a tool for internal advocacy. So someone mentioned from an international agency that the guidelines gave people like him an instrument to use to reinforce his discourse within the organisation. So if someone came to me and said, I'm doing a program that's focused only on PTSD, I can say, this is not only against our internal guidance, but it's also against the guidelines rules. So it's really a way to try and shift programs and quality in that sense. But at the same time, the guidelines are not implementable. They're not a step-by-step list of activities that field workers should do in the field. And so that brings me then to the question of how can we continue to generate and draw upon research to improve practice here. So the first question then is, how can research generate evidence in the field of MHPSS? And I'm drawing here on research that Vitz et al. And others have published that really identified a disconnect between some of the priorities in the field. And this is themes that also came out in the interviews that I did for UNHCR. So here I also want to note that I'm characterising two very diverse groups. Academics often have fieldwork experience behind them, often really do understand the priorities in the field. Similarly, aid workers often are very interested in research. But just to characterise what that tension might be and then to sort of play that out, what Vitz et al. And others talked about in this article is that there's a tension between what researchers are aiming towards in this field, which is really around excellence, creating high-quality, scientific, valid data that can address important research questions. But for example, that there might be a study that's very relevant to do. We might have the question of what is the impact of displacement on the prevalence of domestic violence. So that's a very relevant research question, but if we don't have baseline data from before the conflict or before the displacement, that really can't be answered in the most valid and scientific way. So that could be an example of where this prioritisation of excellence and validity trumps the question of relevance. And that the priorities of aid workers is often, meeting basic urgent needs and generating data that is very readily translatable to the field. And I'll move on here time-wise, but there are some examples that come out in this paper and in examples that I've come across in the field that we could talk about later. And my argument here really is that excessive